Meridional markings are made using my degree gauge, which is very convenient in a small eye like this. Alignment of the toric axis and the initial incision is made. Epithelial scratching is done superficially using the edge of the tip of a hypodermic needle. It's a posterior polar cataract with onion ring markings as well as the radial stretch marks on the posterior capsule. A limbal corneal entry is made and AC is filled with hydroxypropyl methyl cellulose. Limbal floor entry with a cystotome. The HPMC retains the depth of the anterior chamber, facilitating a good and controlled rhexis. With tunnel floor entry technique, there is no loss of viscoelastic, which tends to push the rhexis peripherally as the AC shallows, but here because of steadiness I could complete the rhexis extremely well. Young male presenting with loss of vision, progressive loss of vision since a long time, especially at night time. Lignocaine 1% is used to anesthetize the iris and ciliary body. Hydrodissection is made separating the capsule from the cortex on the left side up to the edge of the cataract. From the right side, I do a hydrodelineation to completely separate the epinucleus and the nucleus from the cortex. Alternate rotation is made in the epinucleus and nucleus and the cortex using two instruments. You can see the central plug of the posterior polar cataract has come out now, exposing the central posterior capsule. This is the most crucial time when you are not supposed to either shallow the anterior chamber or balloon the anterior chamber, putting the posterior capsule into a stretch. AC is maintained very delicately using visco infusion continuously with my right cannula. Slight pressure on the posterior lip of the tunnel and gentle visco expression removes the cortex and epinucleus from the anterior chamber. The central posterior capsule is exposed and you see the ring of the posterior polar cataract. The central plug has already come out. As and when the posterior capsule is exposed more and more with the cortical aspiration, it becomes more and more stable, more and more safer. Now the risk of posterior capsular tear is getting eliminated, and this technique allows very fine control of the anterior chamber depth. The Simcoe cannula is attached to the silicon bulb, which is held by the right hand, controlling the pressure inside the anterior chamber extremely delicately. The risk of posterior capsule tear is extremely minimal in such situation where both aspiration and infusion are under very fine control. Through a slit cartridge, the IOL is inserted into the capsular bag, rotated so that the axis aligns to the markings that you made on the corneal periphery. It's very important to remove the visco completely from the capsular bag, from the back of the lens, back of the cornea in the angle region, and align the markings perfectly onto the corneal markings. Form the chamber, the pressurized normal levels of intraocular pressure, and there is no need to hydrate and there is no need to bandage. Excellent results. Thank you very much.